So today we have Dr. Robert Uzzo, who's an MD and also has an MBA, and he's a fellow of the American College of Surgeons. He's the chairman of the Department of Surgery at Fox Chase Cancer Center at Temple University Health System. And he has so many titles, from Endowed Professor, Chair of Surgery, Deputy Chief Clinical Officer. He's also the president of the medical group, and he has a list of titles that is so long, but we're gonna actually publish. It's gonna be on the website in Grand Rounds Urology. So Rob, thank you so much, taking some time out of your busy day, particularly during this crisis.
Thank you very much, Fernando. I appreciate this chance. This has been a lot of pressure on all of us to try to get it right. We're fighting a war on two fronts, right? We're fighting a war against the biology of cancer and a war against the biology of a virus that is unknown to anything we've ever seen before, right?
Yeah, there is no playbook for this crisis, I think, and I personally have learned a different meaning for flexibility and capacity. So flexibility to really try to go from telehealth to telephone calls to virtual clinic and so on, and capacity trying to understand the recommendations of the U.S. Surgeon General, the government agencies, the institutional policies and guidelines, all this to make sure that we have all the equipment and the personnel to take care of patients with COVID-19. So in this time of really high anxiety, we need some guidance from leaders like you. And you just said something very wise. We have two fronts, and the cancer and also the war against SARS-CoV-2. What are the established guidelines or recommendations from your institution and from leaders like you that is in one of the major cancer centers in the world?
Well, let's start by saying that this is all so rapidly evolving, and we're all learning unbelievable lessons as we go through this, as you pointed out, right? You never let a good crisis go to waste, right? So in the midst of all this, we're trying to reconfigure operations and processes and how we communicate with patients and how they best understand the trade-offs and the risks. We're having much more rapid and in some ways honest discussions, not that they were dishonest before, but that it just sort of boils down to the bare essentials sometimes. People are afraid that they're going to have collateral damage from this pandemic, that their disease is going to progress. They're afraid at the same time that if they get treated, that they're going to be rendered immunosuppressed and be more likely to sort of succumb or be susceptible to the virus itself. So trying to balance all those things in the complexities of U.S. healthcare delivery, with resource constraints that we're not used to, is an unbelievably major challenge, and it hits everybody, sort of the same, and in many ways, it also hits them differently. So we've sort of tried to establish guiding principles, for how we sort of render the decisions, the difficult decisions. And I think everybody sort of can agree that, that those guiding principles include to sort of keep patients safe, to keep staff safe, and to sort of allocate, limited healthcare resources appropriately, and at the same time to try to deliver care at the highest level. And so, we've gone through, multiple iterations of what that looks like in our institution.
Mm-hmm. And let's say you're one of the world experts, for example, in kidney cancer. And in terms of small masses, I think, if you can take care of the anxiety of the patient, you can really delay their aggressive treatment if they desire to do so. But in terms of larger masses, metastatic disease, is there anything that scientifically we don't know if cytoreductive nephrectomy or checkpoint inhibitors target therapy can be really efficient to give some measure of treatment in this time of crisis? What do you recommend? What did you recommend in terms of taking care of these patients to your colleagues or your residents, fellows at your institution?
So if I can, let me just sort of take a step back and sort of talk about strategically how we tried to manage this in the last week or 10 days, because it's evolved, very, very dramatically. Early on, we recognized that there was a mounting problem on the horizon, and that we were going to have to figure out how to determine who was the most important patients to sort of expose to the healthcare system. So we started by invoking, physicians' discrimination. We asked them to use their own discretion to sort of ask the simple question, can this case be put off for 4 weeks, 6 weeks, 12 weeks? And ask that question. And if the answer is that the case can safely be put off for 12 weeks without any real risk to progression, biological progression, then we ask them to do that. And what we noticed is that individual physicians were using sort of different sets of discriminatory rules or judgment, so that some people thought that, it was important to, an intermediate risk prostatectomy, while others thought that all prostatectomies could safely be put off for, a 12-week period. And so what was happening is, and that goes across not just urological oncology, but other surgical oncological specialties as well. Because what was happening is people were using all sorts of differences in sort of the way they were counseling patients and what patients were coming to the OR and what patients were getting exposed. And what that did is that sort of caused a collective rethink, because people were questioning, who was right here and who was wrong. And asking, well, why is it that if a 65-year-old person with a Gleason 4+3 goes to see Dr. X and gets an operation, that a 57-year-old person with a 4+3 that sees Dr. Y is not getting that same operation. Now, recognizing that behind each case is a very unique set of circumstances and stories, we had to take that up a level. And so we went through this exercise as Department of Surgery, which I lead, to ask the simple question, let's go red light, green light, yellow light, and tell me all the cases, and let's socialize, the cases at each of the disease sites groups. Let's socialize each cancer at that level as best as we can and bucket them into can wait, should wait, can't wait, green, yellow, red. And once we did that exercise within the divisions and disease site groups surgically, we brought it up, to, the departmental level. And then we had that conversation at the departmental level. And that really was actually another enlightening period, because, many urologists don't necessarily always think of head neck cases or esophageal or thoracic cases, and how do those, red light, yellow light, green lights compare to the ones in urological oncology, right? Because we had to have some level of equipoise for hospital resources and utilizations. And so what we did over the course of, the better part of several hours and multiple phone calls is we came up with a strategy. And in fact, we recently wrote up a similar paradigm, and it's published, I think, as of today online in Annals of Internal Medicine. Alex Kutikov was the first author, but all the department chairs were also co-authors. And here's what we got, to be specific to your question. We came up with, in terms of kidney cancer, we came up with red light, meaning, should not wait, was patients who had low volume metastatic disease that had an excellent performance status, and we really believed in these cases with minimal metastatic disease or locally advanced disease, that those people can go on and they can get systemic therapy whether they had, high volume metastatic disease or low volume metastatic disease. We basically bucket them into systemic therapy in light of Carmina, with very rare exceptions. And I started to allude to them a minute ago. Those very young people where the vast majority of the disease was in their primary tumor, and maybe they had one or two small pulmonary nodules that were either indeterminate, possibly even could be resected. We thought in cases like those, we may warrant an exception, but otherwise, all metastatic kidney cancer cases should go to systemic therapy. That was our red light for kidney. Our yellow light for kidney was, you can consider it, but it's a discussion, and it's got to be a consensus discussion with your colleagues, is no surgeries for clinical T1 kidney cancer. Planned partial or radical nephrectomy for clinical T2 should be considered for delay based upon patient-specific considerations such as age, morbidity, symptoms, and tumor growth. And for clinical T1 or T2 masses, it was believed that delaying surgery by 3 months was not really associated with decreases in cancer-specific or overall survival. So those were yellow lights, for conversations and for discussions. And the ones that we thought in kidney cancer could be done and should be done surgically, I'm talking about surgically now, is nephrectomy for T3 disease, including patients with renal vein or renal cable involvement that is otherwise localized. That is, patients where the disease appears to be perhaps aggressive, but not metastatic. And for those more advanced tumors, especially those with thrombi, it was believed that that they may progress rapidly and create more complicated surgeries that adversely affect survival and or surgical mortality, and therefore they were green light. So I could go through them for bladder cancer and for prostate and testis cancer as well, but we did that sort of exercise with each of the cancers that we treat, even penile cancer and the lesser common cancers. And so if it was green light, basically you presented it to your group, everybody agreed. If it was yellow light, it was a conversation. If it was a red light, you simply didn't do it.
So because we do have to think about capacity and predict if the patient after bypass will require more blood transfusion or will be intubated for longer period of time. So those are considerations that you're pointing out also that comes into the algorithm, something that we did not consider heavily in the past. Am I getting the correct message here?
No, absolutely. So we obviously have to contextualize all of this within the resources available at each of our hospitals and the anticipated hospital stay, because it's believed that the exposure, obviously to the faculty, to the staff, to the nurses, to anybody who walks into that patient's room, and to the patient themselves, extends, well beyond the period of their operation. So we now have, as most places do, I'm sure, dashboards that tell us how much blood we have on hand in the blood bank, what our sort of running rate, what our run rates are, and all the supplies, et cetera. So obviously, nothing that's green is evergreen and nothing that's red is always red. These were the best guidelines we could come up with. But if a person had T3, tumor, including, that with a level 4 thrombus, and we're running low on blood, frankly, that patient would likely have gotten, a biopsy and a TKI or some form of immunotherapy as a hold-off measure.
I see. And would you, let's say, I don't want to go too much off on this idea, but we're considering so many different factors nowadays that we did not consider in the past, i.e. The age of the patient. If you had the same disease that you would consider surgery, are you considering the age of the person if they're older than 60, 65, or they're 50, 45 years old? Of course, let's say the same ECOG performance status, but just the age being a factor. Is that something that weighs heavily in your decision, in your discussion with your colleagues?
I would say that age as a standalone factor is not the primary determinant as much as physiological age and competing risks and comorbidities, and pre-existing conditions. And of course that's got to be contextualized against the biology of the cancer that you're treating. So let me just go through bladder cancer, for example, right? So cystectomy, muscle invasive bladder cancer, is believed to be, in our mind, green light, because there's data to suggest that delaying cystectomy by 90 days or more increases the N positive rate, decreases overall and progression-free survival, and is associated with a higher pathological stage. So, so in general, muscle invasive bladder cancer, was something that was green lighted by our group. There was a lot of discussion around neoadjuvant chemotherapy. For T2 disease, it was sort of felt that the benefit is there, but it's probably less robust than for T3 or N positive disease. So those people we would send to neoadjuvant chemotherapy, but the straight up T2 disease, cystectomy was going to go straight to cystectomy, or is going straight to cystectomy, assuming that the resources are available to do that. And as you say, you've got to put that in the context of if the patient is, frail or otherwise comorbid and older, then that's got to be taken into consideration. But as a pure rule, is there an age cutoff? No.
This is great. So there are two other questions that I just want to ask you. One is in terms of system-wide. If you see our colleagues in Europe, sometimes they think that we're too aggressive in terms of surgical treatment and so on, versus active surveillance for some diseases. Do you think that we'll get some more uniform international guidelines for diseases due to this crisis that we're having? What I'm trying to say is, do you think that we're gonna probably think about capacity, flexibility, all the different ways of approaching a disease? And the second last question, I just want you to think about, you're a leader, you're a scientist, a surgeon, you have so many mentees, and that's a big burden and exercise, and not burden in a bad way, but in a good way. How do you think we're gonna see education for our fellows, for our residents, not medical students, but the practical, the Houston model of do one, see one, see one and do one and teach one. But do you think there's going to be an acute, I'm not trying to get like a crystal ball from you prediction, but what are your thoughts? Just curiosity,
Well, I think, first of all, we're going to all grow tremendously through this crisis. We've had to ask many questions about allocation and triage and the trade-offs between, the risks of the tumor versus the risks of the exposure. I think that all of this is going to bring us to a position where we're going to have to become more efficient. We're going to have to become better allocators of those resources, and we're going to have to be better communicators to the patients of risk, right? So when patients hear the word cancer, they automatically believe that, cancer-specific death is, an inevitability if they're not treated immediately. At least that's how many of our patients approach it. And so the conversations that we're having now really are attempts to step people back from that ledge and explain to them that, good treatment and good care, doesn't require them to have it tomorrow, and to balance that risk against the risks of being exposed, in the system, or being in a system that either doesn't have the resources to support the possible complications, or that will, cause the system to use resources that it's not prepared to use, given the uncertainty of what this pandemic may look like. Mm-hmm. So if you want to sort of think about what it looks like a year from now, is there more uniformity in terms of how long we can wait to take care of some of these diseases? I think inevitably there'll be, immense anecdotal experience that, could never have come, outside of, this crisis, and that people will be able to debrief from it and perhaps collect some meaningful data to suggest that these delays really weren't as, as sort of troublesome or biologically dangerous as we may have thought before we were forced to make these tough decisions. It's possible they could find situations where it really actually was worse than we thought, and patients did suffer some collateral damage. One of the hardest things, is prostate cancer. This was one of the ones that really took the longest to adjudicate, because some of our faculty felt that all prostatectomies should or could be delayed, and for high-risk disease, ADT should be used or at least considered to hold off the role for prostatectomy. Whereas others thought that, particularly in young patients, that a 3 or 6 month delay for prostatectomy could potentially be the difference between curative surgery and non-curative surgery. Here, and we didn't just really make these recommendations in the absence of really pouring through the literature and trying to figure this out. The biochemical free rates may be higher, in high-risk men who delay definitive treatment if given sort of ADT. There's not really a clear cutoff for time, but there's a lot of really pretty good data looking at ADT to mitigate this risk. In fact, there was really recently, I think it's going to be presented at ASCO virtually, a phase 2 trial, I think that Adam Kabel led for high-risk prostate cancer, and he gave abiraterone, apalutamide, and LHRH in patients prior to radical prostatectomy, and found that their pathological CR rate was as high as 20 or 22%. And so, I don't know if that means that the patient is, quote, cured, or if that means that will translate into a longer overall survival, or if that's really a meaningful endpoint. But we looked at things like that when we tried to ask the questions about the necessity to expose a patient to a prostatectomy. Now, it's easy to think that, I could get this patient in and out of the hospital in 16 hours. And that's probably true in the vast majority of cases, but there's all sorts of data to suggest if that patient has COVID, if that patient, is an asymptomatic carrier, that perhaps, even the laparoscopy or the robotics can sort of expose the operating room staff, and all sorts of considerations that we're really just flying a little bit, without the data. And so making these trade-offs, figuring out as a team, as a group, as a team, and surgical disease site leader, and then putting that in the context, the unique context of your own individual institution and what resources are available to you, has been an unbelievably productive team building exercise. So from that perspective, I do think that there's going to be a lot of good that comes out of this.
This is very optimistic. It really made me feel extremely more optimistic. And I'd like to thank you again, Rob. Somebody like you that spent almost the whole adult life taking care of patients, and particularly in cancer. I do appreciate your comments. Any other last minute message?
No, your comments are very nice and very kind. I appreciate it. And of course, I am really I believe that we all went into medicine for this very reason, right? I mean, the future is always uncertain, and with that uncertainty always comes fear, but I think in one of my editorials, I sort of quoted a Greek Stoic to cease to hope and you'll cease to fear. And so, the triumph of the human spirit, the triumph of the medical system, the triumph of the individuals who've committed their lives to this is, I think, what should carry the day.
Thank you very much, Rob. This was Dr. Robert Uzzo from Temple University. Thank you again, and I'll talk to you soon.
Be well, my friend.
Bye.